Hey everyone, thanks so much for joining me on the Slice of Healthcare podcast. I'm your host, Jared Taylor. On today's episode, we're bringing him back, Dr. Matt Lambert, the Chief Medical Officer at Curation Health. Dr. Lambert, how are you today?
I'm good, Jared. Thank you so much for having me back on the program. I appreciate it.
Absolutely. It's a good sign when people come back. It's a really good sign, and we really, I feel like our rapport will continue to build. And we had Kevin recently on a second time, and it was a really good conversation. So these next conversations you and I have, and Kevin, and whenever someone's on twice, it's a deeper dive, right? It was a highlight before, it's a deeper dive. So today, you and I are going to focus in on training clinicians and residents to succeed in value-based care. So I'm excited to learn more from you, and I'll let you kind of kick things off.
Sounds great. So we see challenges in moving to value-based care, right? And there are a lot of them, and it's not a subtle shift. And I think even a lot of the health systems who have even taken a big step into it or realize that once they're in there that they're really going to have to do things a little bit differently. And from the health system side or from a plan side, it really requires a year and a half worth of investment. Or looking down the road, because you're not going to see the fruits of your labor or the fruits of your change until for about a year and a half down. And that's tough for a health system that's historically been fee for service and historically managing P&L 30 days at a time and not 30 months at a time. So there are a lot of barriers there, but one of the barriers of the actual of the challenges of moving to it is at the clinical level is that a lot of times we're asking providers to do something that they weren't trained to do with a tool that wasn't designed for it. And maybe it's not part of the compensation model. So let's break down the pieces of that. Most providers are trained in an E&M world, evaluation and management codes, a fee-for-service world. And these came about in 95 and 97. And I'm old enough to have that have happened in my training. And I listen to a lot of the doctors lamenting, well, we used to just be able to write whatever we want. Now we have to meet these certain markers with our documentation. We have to have a chief complaint. We have to have a history of present illness. We have to do a 7 body part physical exam. We have to do a review of systems. You had to do that in order for it to get reimbursed for that care that you were giving. So we were really trained to think in that way, and never underestimate how beholden we are to our training. Right? Physicians are just like all of us. Tend to be most shaped and formed during our early years, right, or formative years, and things that you learn in residency you really carry with you. So a lot of those trends are hard to break. Second piece is electronic health records. We got to electronic health records, and they're designed for an E&M output, right? They're designed to produce the type of physician documentation that will match to the reimbursement model. So that's the part where we're asking them to use a tool that really wasn't designed for that. And it's been really interesting to see a lot of, and that's one of the things that we do at Curation Health is really kind of help bend that technology and bend the workflow to something that makes more sense in a value-based care world than in a fee-for-service world. And and a lot of that bases on the diagnosis itself. In that E&M world that I was talking about, the volume of documentation mattered. Or making sure you were checking certain boxes. The actual specificity of the diagnosis didn't matter. Value-based care world, that is completely flipped. The specificity of the diagnosis is what contributes to how CMS and how the payers assess risk. So that diagnosis has got to be specific, and that's new. That wasn't that way before in an E&M world. And then the other barrier is comp, right? A lot of groups are still comped on an RVU or fee-for-service model, where your compensation model is based on volume and not necessarily outcomes. So if you're asking someone to do something they weren't trained to do with a tool that wasn't designed to do it, and even though they're not going to see an immediate gain from that, you're going to have limited uptake. So we have to change this course and change this process with a lot of folks who are in mid-career and help bring them along. But I think it makes the most sense, since we're so beholden to our training. Let's start doing this in training, and let's start training providers to think a little bit different focus on a little bit different things and actually behave and document and engage technology in different ways. And so a lot of the challenges with that are where you go, where you get your training. Academic centers traditionally are still on RVU and fee-for-service models. The comp models are a little bit more antiquated, especially if you go to a really big academic center, university academic center for your training. You're probably not going to get a lot of value-based care training. Now you'll get training and to be efficient as a clinician. You'll get trained to be thoughtful of, am I ordering the most appropriate test? Am I not ordering the most expensive thing all the time? Although a lot of academic centers are referral centers, and so a lot of times they'll be spending more because they're taking care of the sickest patients. But that you're not going to necessarily get that at a true academic center. You probably see more of that when you go to a residency program that's affiliated with some of the places that really do a lot of value-based care and do it well. So I think of Kaiser, out on the West Coast. Anybody who gets training at Kaiser Permanente, it just has this baked into some of the processes because that's how those hospitals operate. Move to the other coast, get into Geisinger in Pennsylvania. If anyone who's training at Geisinger is going to learn a lot about value-based care and a lot about the ways to adjust their clinical thinking and their documentation around that, because that's part of what Geisinger does and has done for a long time. So I would think if for a resident now, let's say I'm graduating medical school now, or I'm looking at where I'd like to match, if you really want to be a part of the value-based care movement, then I would consider maybe some of those. I'll call them alternative residency sites, or ones that are affiliated with health systems who really do a lot of capitation and value-based care to begin with. I would encourage, my colleagues in the academic space, maybe someone who's watching this, or even friends at the AAMC, just down the street here in DC, about the incorporating this as a part of models moving forward, especially in the primary care space. And again, it's the essence of the medicine that you're practicing is not going to be that different, but the way that you document it and the way you present it to CMS or to the payers is really going to make a difference to make sure that you are getting credit for the complexity you're managing. And again, and just getting it as a part of training or incorporating that in training is going to make when we're a generation of physicians away from now, they'll all be used to a value-based care world. Long soliloquy on value-based care and training, but yeah, I think we should, if we really want to accelerate this, we need to think about the comp models. We need to think about the technology. We need to think about the way we're training providers, and that takes us directly to the way we train them in general residency.
That was excellent, and I was quiet the whole time because I was not going to disrupt that flow. It was perfect. I really like it. I have one question out of that, though. Do you envision, and maybe when do you think that point comes, when certain people, I guess, in medical school, do you think there's going to be in the very near term a generation of clinicians and like residents that only know value-based care? Like, when do you think that point comes? And do you think it will ever come, or will we always be like, there'll be a percentage of like kind of going back and forth? I'm curious because I think that'd be really interesting to find out.
We have a generation of physicians right now who have never written a prescription, right? They've only clicked on a prescription. So I was working with a resident the other day, and we're having some challenges with the prescription, the automatic piece. And so I pulled out a script pad and handed it to her, and she looked at me like, "What do I do with this?" So yes, we'll absolutely have a generation of providers who don't know anything different. And it's going to be, I mean, it'll be at least a decade, I think, maybe a little bit longer. But that kind of goes to the whole the challenge with the operating model anyway. So Jared, we see you can do 20% of your business as value-based care and still not change anything that you're doing, right? You not change your operating model, not change your comp model, not change that. You can have up to 20% of your patients enrolled in a value-based care plan. For value-based care to make sense, as you have to have at least 2/3 of your patients in there. So a lot of the market is stuck between this 20% and this 63% hurdle that you have to get through for it to really make sense. So the ones who are in that far right group have already fully embraced it. They're way ahead and they're pushing the market. And a lot of that is in, Medicare Advantage and in-home primary care, full risk, full capitated. But I think we'll when we start getting people entering who are trained in value-based care is when we're really going to see us get over that 1/3 to 2/3 gap where we're kind of stalled out right now. And I don't want to say stalled. That's not the best word, but that's the biggest barrier. You can do 20% of value-based care and not change a thing, but if you're going to embrace it, you need to embrace it at least 2/3 of your contract for it really to be your new operating model. And I think you see that a lot in any sort of change management, right, or change process or market adoption, right? There's that first 10% is pretty slow, and then the adoption curve really gets steep until you get up to about 90%. So I think it'll follow that same sort of thing. But yeah, we'll completely have a generation of physicians in 10 or 15 years that only know value-based care.
That'll be really interesting, and I think that's when you'll start to see. Obviously, we've already been starting to see some positive changes now, yep. As value-based care becomes more of a focus, right? But I think that's when you'll really start to notice that shift when that's all that that's all that they know, right? And hopefully we, as a result, we start to see those healthcare costs, because you and I talked about this before the podcast. It is insane to me that if you took the U.S. healthcare portion of GDP and you made that its own country, that is the 4th largest GDP in the world. That is insane. Absolutely crazy. So my mind was blown when I heard that stat. So I think value-based care helps us significantly reduce that, whatever it is, $3.8 trillion a year spend, which is insane.
Yeah, it's completely unsustainable, right? And I think that's that's the whole crux of this, right? And value-based care, I'm sure, the perfect model doesn't exist, right? And it has its challenges as well. And I'm sure there will be some unintended consequences for this big of a market shift, right? You're changing the economy of the 4th largest country in the world, right? But we've got to find a way for a more sustainable path, and otherwise it's just going to pull us down in other areas, so many other areas of our society, and other things that we could be investing in, and that really opens up, SDOH too, right? If there are other funds available, other than managing, healthcare in its current state, then that would free up some other investment that we could, that would improve people's health otherwise in the communities as well. I'd love to see us reinvesting in a lot of communities in this country, not just with infrastructure, but in every way. And behavioral health too. I'd love to see more investment in behavioral health.
Absolutely. Well,
yep.
Dr. Lambert, it's always a pleasure. This won't be the last time you're on, so look forward to doing some more stuff. You and I talked about maybe even, we'll do a little teaser here, but maybe even a panel in the near future, which will be really exciting with some of the other organizations that are really pushing forward value-based care. But always a pleasure chatting with you and Kevin and the rest of the Curation Health team, and look forward to having you on again real soon.
Thank you so much for having me, and I'm already looking forward to the next time.